Hello and welcome to On Call with the Prairie Doc. Rheumatic diseases appear when bones, joints, muscles, or organs such as the lining of your lungs or heart become inflamed. This inflammation can arise due to normal wear and tear, an injury, or even your own immune system attacking your own body. Pain comes with tenderness and swelling, and the result may be a limitation of your ability to engage in normal life. We answer your questions as they arrive. Should there be more questions than we have time to answer during the broadcast portion of this show, we will continue live streaming on our website after the show in our after hours portion of the evening. And to view that, go to online oncalltv.org and follow the directions there. Well, call in your questions right now, 1-888-376-6225, or email us at ask@oncalltv.org. Joining me tonight to discuss rheumatic diseases and to answer your questions is a good friend of the show, Dr. James Engelbrecht of the Regional Medical Clinic, Aspen Centre, Rapid City, South Dakota. Welcome back to the show. This must be show number 2008 for you, I think.
It's always a pleasure to do it with you. I enjoy doing it.
Thank you so much. So you're a rheumatologist. Where did you train?
I went to medical school at the University of Iowa. And
you're an Iowegian, aren't you?
Yeah, I am. Yeah. I am. Born and raised in Lamar's. Medical school at the University of Iowa, then I went to the University of Utah for my postgraduate training. I did internal medicine, and then I did the fellowship training in rheumatology, and then started moving back towards the Midwest and got as far as the Black Hills of South Dakota and got stuck.
There you are in Rapid City. So you're a rheumatologist. What is a rheumatologist by definition then?
Well, rheumatologist is a specialist in rheumatic diseases or autoimmune diseases. Rheumatology is one of the specialties in the internal medicine field. So internal medicine, as you know, is a broad field. You're a general internist, do internal medicine training, and if you have a particular interest beyond that in the heart or in the kidneys or in rheumatic disease or whatever, then you take fellowship training and spend a couple of years sort of refining skills in that particular area, and that's what I did in rheumatology.
Yeah, and you did that, and you're also the chief resident at the same time.
I was chief resident. Yeah, I did a lot of things.
That's a feather in your hat. I mean, people don't realize chief resident is a big deal and a big training program.
It was.
So, but you know, rheumatology is the training in rheumatology. What drew you into it? I mean, is it that it was so many people were in so much pain, or what?
You know, the several things. First of all, rheumatic diseases cut across all of the organ systems. I know that arthritis, we're talking about joints and you know, muscle and bone and one thing or another.
Right.
But that's just a manifestation of the rheumatic disease. Very often it's attacking, like you say, the lining of the heart or the kidneys or some other area. So the broad nature of the involvement there, and then the fact that the people that were my mentors were really terrific clinicians. I mean, they could sit down with a patient and by taking a history and doing a physical exam, have a pretty good idea of what was going on, and I wanted to be part of that. And rheumatology really got me into that.
That wonderful clinical acumen, as they say, of an internist and as a rheumatologist, that knowledge base. So, I mean, how do you make the diagnoses of a lot of these different conditions?
You know, they're complicated conditions, as you know, but they all have certain guideposts along the way. There's age groups that are specific to some things. There's skin involvement and certain patterns of skin involvement. There's joint involvement, certain patterns of joint involvement, how the disease started, what was the onset like? Did it just drop out of the sky like that one day, or was it gradual? All of those things that you get by taking a history and then actually examining people and looking at their skin and
touching the patient.
Yes, you know, that real examination business, you know. And then, you know, once we do that, we have a pretty good idea of what we're dealing with here. And then the lab or X-ray or whatever really becomes confirmatory. I really don't want to depend on some imaging study or some lab to tell me what's going on. I want that to confirm what I think clinically.
Right. I know. I knew that when I realized people were coming back with the diagnosis of rheumatoid arthritis, but doesn't have the positive blood tests for it. In other words, the blood test doesn't confirm it, but they've got rheumatoid arthritis.
Right. Well, and that's, again, there's been a refinement in some of the blood tests for rheumatoid arthritis, but as a general rule, probably somewhere in the neighborhood of 10 or 15% of people with bona fide rheumatoid arthritis, okay, potentially crippling rheumatoid arthritis, can have negative blood tests. Okay, so if you're going to depend on those blood tests to make your diagnosis, you're going to miss it, 15% of the time, okay?
Yeah. So in other words, it's a clinical diagnosis. You make it when you see the patient, you hear their story, and you examine them.
That's right.
I mean, I think there's a lot more in medicine than that. I mean, and of course, patients, I think, or people, presume that there's a CAT scan that we can do that will make the diagnosis. What's your take on that?
Yeah. Well, listen, the imaging studies are fantastic. We can get to the source of something, but you've got to have that clinical roadmap first. Otherwise, you just end up doing a bunch of tests for the sake of doing tests, and then somebody's got to sit and try to make sense out of all these tests. Why not figure it out pretty much first, and then use the tests to confirm what's going on?
So I don't know how important, I know how important you feel about it, but I don't know how important people realize what he just talked about. That this is probably the most important thing to realize, is that new doctors maybe don't realize it, that their experience, the physician's experience and knowledge and exam, and more than anything else, the history, is the most important tools we have in our diagnoses.
Right. Well, and there's this constant rush right now. Oh, we got to get there quickly. We got to know what so get this scan, that scan, and then you say, well, gee, what did the patient have? And well, I don't know what they had. I just thought this CAT scan would tell me the answer.
Yeah. Talk about DEXA scanning, which is a test for bone.
Yeah, osteoporosis and bone density. Okay, and it's one of the being a rheumatologist, it's one of the areas of our expertise is in osteoporosis and other metabolic bone diseases. Okay, and I think that's the important thing. The DEXA is a very good imaging study to assess bone density. It does not give you a diagnosis of osteoporosis. You don't do a DEXA and out comes a thing that says, oh, this is osteoporosis. What comes out is, what is this bone density? Is it normal? Is it abnormal? Is it low? If it's low, there are a lot of causes. Okay. And one of them is osteoporosis, but there's a list of other things. And so you just,
vitamin D deficiency, lack of exercise, certain arthritic,
endocrine disorders, hyperparathyroidism, cancers, myeloma. There's just a lot of things. Osteomalacia with the vitamin D.
Yeah.
So I tell the students and the residents that I teach, they should think of the DEXA as a CBC. That's a hemoglobin. Okay. So it tells you you've got somebody that's hemoglobin is low.
They've got anemia.
You just don't give them iron.
You got to
figure it out.
Why could there be colon cancer?
That's right. What's going on? The same thing with the bone density. I think that's a
important point. And we'll talk about gout in just a minute, but gout has been with us for a long, long time. It was first identified by the Egyptians 2640 BC. It's a painful and debilitating condition, but with attention to lifestyle and judicial use of drugs, a sufferer can control the disease.
Gout always in the big toe, and it would alternate, but pretty soon there was other places. And I had, this elbow was pointy compared to this elbow. And I didn't know what that was. Well, the doctor told me that I probably should see a rheumatologist. So I went and saw the rheumatologist in Sioux Falls, and he looked at my elbow and he says, I think that's a tophus. And we'll bet, and it's possible that could be uric acid. So he examined it, and we got some fluid from that, and he looked at it under the microscope and came back and says, you lit up like a Christmas tree. Oh my. He says it's probably going to take 2 years to get rid of all this. But then also we have to do some work with diet also. And I remember him mentioning some of the things about diet, and he looked at some of the foods that you should be eating, and these were some of the healthy foods. No, your high uric acid or purine foods. And so I looked at those, and we can work with that. And then he says another thing would be alcohol. He says alcohol is pretty much a no-no. He says that's really will cause flare-ups. And I said, well, I don't drink that much anyway. And he says, well, probably best no alcohol. The one thing that I really found helps was if you do get an attack, get on your anti-inflammatory right away. Because the sooner you can get that joint loosened up again and to get those crystals out of there, the inflammation will go away too. And keep drinking plenty of fluids. And if they do tell you you should go on some medication for it, like a lifetime, like the allopurinol, do it. Because, like I said, it's an unforgiving condition. Because I've noticed I have other joint problems now, possibly really, because they say that it damages the joint, and so now we're going to see arthritis and some other things start to show up. I usually start out with about 50 to 60 minutes of walking, a faster walk, not just a real slow walk, and then I'll go in and do upper body stuff, and then now recently we've been doing more of the stretching and balance type exercises afterward for the next 20 minutes. Otherwise, usually I do about 65 to 80 minutes of exercise. Usually what I see as far as improvements, I stay in better shape. I can do more things, and I'm not as stiff during the day, even though there are different times I exercise when I probably do have some pains, but it's things that I try to work out with the exercise. And I could exercise at home, but I choose to come to the wellness. It's like as though it's a stop off before going to work, but at the same time, I have a lot of friends here now, and exercise becomes so much easier when you have other people to do it with.
So that last picture was uric acid crystals polarized, so they were turning green and lighting up like a Christmas tree. Yeah. Great. Thank you for being our guest on that story. So rheumatoid or gout and rheumatoid arthritis are related?
They're not related. Gout is a crystal-induced problem. It's a metabolic thing where you overproduce or underexcrete uric acid. It builds up in your system. It sort of deposits around different places, and then over a period of years, all of a sudden, those deposits can break loose. And that crystal in the joint is what provokes this very strong inflammation, and it can be one of the most painful things. They talked about the big toe. It's often in the big toe, but big toe pain isn't necessarily gout. Okay. And gout doesn't necessarily have to hit the big toe. It can be in the knee, it could be the ankle, it could be the wrist, it could be the elbow. We've seen it. You see it everywhere.
It can look like rheumatoid arthritis sometimes.
And that's the other thing, is it becomes what we call polyarticular. So it can involve many joints, and as it involves these joints, it can begin to look like rheumatoid arthritis, and so will be misdiagnosed. The treatments for rheumatoid arthritis do not work for gout.
So, they're totally different, aren't they? But now I've taken or I've seen patients who were treated for gout, and their gout got worse. What's that?
Well, there again, you have to understand that the body is at equilibrium with this uric acid. It's in the tissues, it's in the bloodstream, or whatever. And the body, what doesn't the body? The body does not like upsets in equilibrium. Okay. And so if you do something, overeat certain foods, drink too much, take certain medications, you can upset that equilibrium where you drop the uric acid, and so you're out of balance, and all of a sudden those crystals around those joints start to move. And when they move into that joint, you get the inflammation. And so that's why checking your uric acid level is so important to do when things are quiet. You don't do it during an acute attack because you don't know what's moving. So the equilibrium is what gets disrupted, and that sets off the gout attack.
Right. So I use allopurinol mostly to try to lower the uric acid level, but it can sometimes set that off. And that's
because it drops that if you use too much. But the trick there is to use a small amount. People lot of docs don't even realize it comes in 100 milligram tablets and
Right.
300 milligram tablets. I sometimes, in a severe gout patient, will take a 100 milligram tablet, have them cut it in half, start with 50 milligrams, and very gradually work it up so that I don't upset that equilibrium.
Yeah. Wow, that's an important thing. And you make the difference. I mean, you've had rheumatoid. You've told me stories about people who were sent to you for their rheumatoid arthritis.
Had gout. And you know, I had people literally years ago coming with holes cut in their boots where they had the big gout deposits sticking out the side of their shoe or their boot or whatever. And if you can treat that, and all that will eventually resorb.
Yeah, it's amazing. I've seen patients come to me with gouty tophi, these big with oozing uric acid crystals, and I thought, oh, there's an infection on the no. It was
See, the other thing, you know, with those crystals, if you have a tophus there or something, you can just nick it a little bit, put it on a slide, look at it under the microscope, and you see the uric acid, you got it.
You got it. Now we're talking rheumatoid arthritis. This person said, has rheumatoid arthritis, taking methotrexate, or was taking it, was switched to azolvedine, wondered if azolvedine is a drug to replace methotrexate, also would like to know how these drugs affect her other organs.
Okay. So, methotrexate is kind of the foundation drug in terms of treating rheumatoid arthritis, okay? And 30 years ago, really got turned on and it was a big deal. Azolvedine, which is a sulfa medication that's been around for a long time, also is very good for treating rheumatoid arthritis. And in fact, we use methotrexate in combination with azolvedine and in combination with another drug called plaquenil or hydroxychloroquine. That combination of those three medications is called what we call triple therapy.
That was, again, azolvedine, methotrexate, and
plaquenil, hydroxychloroquine. So so those three drugs, if you Google triple therapy,
that's what
you'll find. You'll
and
read
it works
about that.
80%.
It works and
combination 80%, 60%.
That combination probably is as good as the biologic medications. Okay, I mean there have been recent studies that have shown it is just as good preventing the damage that rheumatoid arthritis can do as some of the Enbrel, Humira, Remicade.
I had an internal medicine meeting 2 years ago that said methotrexate works 60% by itself, 60% of the time, and you don't have to go to those very, very expensive medicines because methotrexate's dirt cheap.
I mean that's and then you know the safety part. You know, we were very nervous with methotrexate back in the 80s because we thought, oh, you know, we're going to poison somebody's liver one thing or another. And it turns out the doses we use are so small that it really is relatively, I mean, there's nothing that's perfectly safe, but it's relatively safe. And so we really don't have a lot of issues as long as you monitor people appropriately. So every 3 or 4 months we do a blood count and we check liver enzymes and things like that. But, you know, it's to prevent this terrific damage that we have some pictures of. That's what methotrexate can do. It can prevent that.
So this show is only as good as the questions that we get from you guys. So if you want to ask a question, call in and ask us. Call 1-888-376-6225 or ask at oncalltv.org. So we need your questions. Please give us your calls. This is a great opportunity for having the best advice from the expert on rheumatology. I wanted to ask about the cause of rheumatoid arthritis. I mean, you've already made a point that it is diagnosed clinically, but then you do have confirmatory blood tests that works 85%. What test is that?
Well, you know, the rheumatoid factor.
Right.
Has been around for a long, long time.
That's an
but
antibody?
It's not an absolute either, okay? Right. I mean, it's just another antibody that happens to show up with rheumatoid arthritis, but as we get older, we pick up all kinds of antibodies. So you can find maybe 20-30% of people that are over age 80 might have a positive rheumatoid factor.
But they don't have rheumatoid arthritis.
They don't have rheumatoid arthritis. So it's not an absolute. But then there are a little bit more specific ones, and there's a group of antibodies that we call the CCP antibodies, and I'll save you the, you know, I won't go what CCP means, but we don't go into that. But there's a set of CCP antibodies, and we call it, we'll get the CCP or the anti-CCP, and there's actually several of them that you can use, some that are better than others. And that is a good confirmatory thing. And then we use inflammatory indicators. So a protein called a CRP, which goes up when there's inflammation, or a sed rate, which goes up when there's inflammation.
Right.
And there's maybe a little bit of anemia that comes along, anemia of chronic disease. So there's these subtle changes in the lab that can, and these are all inexpensive labs.
Right, and really, you said it earlier, the body turns against its own joints, right? I mean, you have antibody against your own synovial tissue?
The synovial tissue, okay. So let's just contrast osteoarthritis with rheumatoid arthritis for a second, okay? Osteoarthritis, we begin to lose cartilage, it brings to break down, you get bone cysts, and so it's a cartilage bone kind of
destruction
problem. In rheumatoid arthritis, we have the immune system attacking something in that synovial lining, and that becomes very angry and inflamed and throws off all this bad stuff that then starts to rip these joints apart. That's what rheumatoid arthritis is.
So it's totally different.
Totally different.
Now, real quickly, how is rheumatoid arthritis, which is a young woman's disease oftentimes, but it can be older too, though.
Yeah, it can go, but you know, the average age of onset of rheumatoid arthritis is between 25 and 50. Female, preponderant over male, probably 3 to 1.
3 to 1?
Yeah.
So how does that compare to the cause of lupus? Lupus is a young woman's disease commonly.
Right.
How is that different?
Well, and there's a different kind of antibody involved, you know, and it's, again, it's an antibody that is produced by certain cells that either aren't controlled appropriately and get out of control, or overstimulated, and therefore they're producing a lot of complicated immunologic things.
Yeah.
And they basically can go anywhere. For the skin, they can go to your joints, they can go to your lungs, can go to your kidneys, can go to your brain, can go to your blood vessels. Anything is really fair game as far as lupus is concerned.
But is it because lupus is an DNA, RNA? What is that?
Anti-DNA. So there's an anti-DNA antibody, okay? Anti-DNA antibody that we can actually measure, okay, in certain individuals.
And the DNA is in every cell. It's in the nucleus.
Well, I mean, this is an antibody that is, to give you an idea of how this might work. Let's say that you're out in the sun and you damage the cells in your skin, and these cells, which normally would be there with a nice nucleus and has the DNA in there, they get damaged, okay? They're getting damaged, and all of a sudden, this DNA is getting out, is escaping. And so you can actually develop an immune reaction to that DNA.
Yeah.
Or if you already have lupus, you know, these antibodies are floating around, they're just looking for this stuff, and they react with that, set off this reaction, and you have this local inflammation thing. And so therefore, you get all kinds of sun exposure skin rashes that you can, you know, people talk about butterfly rash. Butterfly rash is just where you got the sun on your face, okay? Where it's shaded, there's no, you know, like in the nasolabial fold in here, that you don't see, there's no rash, but out here there is a rash.
It's a sun.
Maybe 30-40% of people with lupus could get this butterfly rash, okay? And it's skin inflammation. Or, you know,
forearms.
I had a number of younger people, girls in their 20s. You know, it used to be kind of popular to lay out, laying out, and you know, they'd lay out and get a suntan.
Yeah.
Lay out and get sunburned and get really sick and came in, and that was the first thing that's the first time we saw that they had lupus. They set this huge reaction off with all that UV light exposure.
All right.
So that's how.
Okay. I'm going to erase that, and I'm going to go. Well, here's a picture. Let's see, of a rheumatoid arthritis hand. Now,
so
let's go to this
put
picture.
the other one. Put the other one up.
Yeah.
So here, this is the bones that would be on the back of your hand. Okay. I mean this part of your hand right here.
Right.
Okay?
Metacarpal bones.
And they should technically line up like this. Okay. And you got the joint there.
Right.
And the rheumatoid process affects this joint, loosens all these ligaments, okay, really messes this up. And what happens is these all start to move, and you end up with a hand then that looks like that. Yeah. And methotrexate, asulfidine, Plaquenil, Enbrel, Humira, Remic, all that armamentarium can now prevent this. I mean, if we can get to these people early enough with about 90+% assuredness, we can prevent that kind of stuff from happening.
I mean, once you're there,
and in fact, it's even worse than that. Once that disease process has set in, even though you don't have the deformity yet, we can't. The wheel has been set into motion at that point. So I tell people, think of a clock. I mean, here we go. All right, and if I can stop it right there, we end up right there. Okay. If you wait until it gets out there, you're going to end up there when you should have been there.
Yeah. So it's like a clock. So we need to catch it early.
You got to catch it early.
All right.
Okay.
Wow. Rheumatoid arthritis usually comes on after age 40, but it can come on at any age, causing a variety of symptoms.
I started having symptoms when I was a junior in high school. At the time I was running cross country, so I was putting in, it was during the fall season, so I was putting in a lot of miles every week. And when I first started being really sore or having to quit in the middle of races because my knee would be bothering me, I thought that it was just due to overexertion from running. So I tried to cut back on that, but then I started having some other kind of really weird symptoms, like my lip swelled up really big one day, it looked like I got punched, and then I had this rash kind of on my chest and back that wouldn't go away, and then my mouth got completely filled with canker sores, and just kind of really tired all the time, just kind of weird symptoms like that. At that time I went into the doctor, and they did some blood work and got back some really strange results. I had a really high strep titer that was through the roof, really high ANA and CRP rates, which measure the inflammation in your blood or body. But then I also tested positive for Parvovirus, Lyme's disease, mono, West Nile, all of that at the same time. So the doctors were like, what's going on? What's wrong with this girl? I had all of these things that my body was responding to. My doctor currently thinks that I do have rheumatoid arthritis, but for a long time we had a hard time defining it as such. Right now I'm at a point where I'm pretty well balanced out, and when I'm doing well, I do pretty well. My GI stuff is probably something that I more need to manage on a day-to-day basis, where I try to not eat gluten. I've heard different doctors have told me that I shouldn't be eating it, or that I should. I got tested for celiac 5 times, and it's always come back negative. But there is just people who are just gluten, have gluten sensitivities. And then I think since the meds that I'm on do decrease my immune system, the main thing that I found, and especially since I work with kids, is that I just have to I use hand sanitizer. I try to get a lot of zinc. Anytime I get stressed out, it's guaranteed that I'm gonna get a cold or get sick like that within the first week, just because I think my immune system is already pretty stressed, and so I feel that pretty immediately. I had to really learn that when I couldn't control my body, what I really needed to control was my mind, because you have sometimes no control over your body and things happen. And so I think that what I had to consciously recognize is I was going through this hard thing that was difficult to understand, but other people are going through hard things too, and the one thing that I can control is how patient I am, and kind of how I educate myself, the actions that I do, I can still control.
So she talked about having antibodies to, mono and strep, and all these antibodies. What did that mean?
That's why the history and the examination is so important, okay? Because when you have these autoimmune disease, your immune system goes through what I like to call an immunologic convulsion, or they're just shooting out antibodies all over the place. Okay, and these tests are not that specific, and they're just picking up antibodies. Oh, mono's positive, strep's positive, this is positive, that's positive. It's just because you've got an immune system that's really just throwing everything out there. So you really have, and so this young lady, she's a typical rheumatoid arthritis patient where they'll have a lot of overlapping antibodies and different things like that, but you got to focus on clinically what's this looking like. Does it look like rheumatoid? Is it acting like rheumatoid? And if so, let's get after it.
So she comes, and she said something about celiac disease. What do you think?
Well, celiac, you know, gluten enteropathy, gluten sensitivity is something that you can develop, develop. And sometimes the people that are really sensitive to gluten, part of that sensitivity or that hypersensitivity reaction is it can give them a lot of other symptoms, joint pain, stiffness, achiness, sometimes skin rashes, all kinds of things, and can sometimes, you know, really look like some kind of arthritis. So you can test for it. You know, you can do, there's some blood tests. There's a blood test that you can check for it. If you really want to definitively see, go on a gluten-free diet for a month, and that'll change things if that's it. But you know, most people are disappointed if they think they're going to find the answer in gluten enteropathy or gluten
for their arthritis.
For their arthritis, it's just. I mean, I've seen dramatic cases. Don't get me wrong, but just a few.
And so, if you're a younger person and you're developing some symptoms, what would be the symptoms that would imply an immunological convulsion or some kind of immunological problem coming upon?
I think that early on, there's what often gets overlooked are things that we call constitutional signs or symptoms.
Right.
So a real change in fatigue. Now everybody is fatigued anymore with the lifestyles we all live, but I mean, if it's a profound change in fatigue, if there's an unusual stiffness in the morning that sometimes is there, sometimes isn't there, if you see any kind of swelling in the joints, sometimes a low-grade fever, and again, it almost feels like you have the flu, but it doesn't go away. Okay, like I'm coming down with a cold or I'm coming down with flu, but then I think I'm better, then a week later it's there again. It's sort of this on again, off again. That's sometimes how it will start before it really turns into like joints, pain, swelling, skin inflammation, nodules, all kinds of things like that.
So a good clue. And this gal that we just saw, well, if you saw her, you made the diagnosis of rheumatoid arthritis, and you were right. What would be the first thing? The methotrexate?
Yeah, you know, there again, if I thought that was rheumatoid arthritis and we had all those things that were serologically positive, I want to get the inflammation down in her system a little bit using something, either a little bit of steroid, maybe a low-dose prednisone, maybe a non-steroidal anti-inflammatory,
ibuprofen,
and maybe even a simpler medicine like hydroxychloroquine that would help me kind of choke this down just a little bit to kind of see what I'm dealing with. But I'd be very quick when I decided it was rheumatoid arthritis, I'd be very quick with the methotrexate. But then again, now you've got somebody who's in childbearing age, okay, which is what we run into all the time.
Right.
Okay. Well, methotrexate.
You don't want to get pregnant when you're on that.
No. Well, first of all, you know, it is somewhat of an abortifacient, so that you may not carry a pregnancy. Okay, you may just have a miscarriage. You have the teratogenic effects or the toxicity to the fetus.
So the baby may be malformed because of the methotrexate.
Right, and so so that's a big deal. You know, we have to talk long and hard with these young women about these meds.
What about if I were put her on a biologic? Is that going to mess up the baby? Is that going to throw away that pregnancy?
It's turning out to not be much of an issue. But the end of that book hasn't been written yet, so we don't know for sure.
So if
we're very careful in those situations. But
all right, so I'm a childbearing male. I'm a young man. I have a wife who could get pregnant. I'm taking methotrexate. How will that affect me?
Yeah, that could be an issue too. Dose, how much you're taking. We would like to have you off of it if you're going to,
try to make babies.
Yeah, because it could have an effect on the sperm. Again, not as, you're in sort of in the gray area, but you would just as soon not have somebody on the methotrexate.
So if you're going to do that, maybe take some time off of it, sperm bank.
Or if you had things under control and you were going to, then what you do is you go off of it, but you come in with something like you know, the asulfidine that was
Yeah,
mentioned, or
right.
the hydroxychloroquine, the Plaquenil, very safe. In fact, with some of our lupus pregnant patients,
Yeah.
we prefer that they be on hydroxychloroquine when they're pregnant, because they, you know, they do better. The baby does everything, they do better if they're on hydroxychloroquine.
Okay.
So sometimes it's better to have them on a medicine.
All right, we've got a bunch of questions.
Good. Fire away.
Caller had meniscus repaired, now has pain and arthritis in the knee besides biking twice a day and ice. What can I do?
Tough. You know, talk to your orthopedic surgeon who took the meniscus out. I mean, that's you know, that about all you can do is to learn what exercises to do properly, keep that knee strong, maintain your normal body weight. You know, exercise, but non-weight-bearing exercise. Probably shouldn't be jogging.
Yeah.
You know.
80-year-old Sioux Center patient, if pain is in the bottom of the feet and nerve pain, burning pain is something this to be brought to a rheumatologist, someone who has peripheral neuropathy.
Yeah,
do you deal with that?
No, we don't really deal with peripheral neuropathy. Neurologists really deal with peripheral neuropathy. You know, there's a whole workup to find out whether there's some cause for the neuropathy, and it's basically, unfortunately, most of the time you don't find a cause.
No.
But there are some pretty good meds
Thyroid,
available.
B12, beyond B12,
Yeah.
won't hurt you. Yeah?
Right.
Please address tubular fluid that builds up and causes inflammation around the joints. Nutritional recommendation for reducing inflammation. I think he's tubular fluid. They're talking about joint fluid.
Yeah, joint fluid. You know, when you have inflammation, okay, if you just think about inflammation in its simplest terms, you cut your arm and it gets infected. Okay, what does it look like? It's red, it's tender, it's swollen. Okay, what's the swelling? It's fluid.
Yeah.
Okay, well, if something is inflamed in your joint, the swelling comes around there, but it sort of washes into the joint, so you end up with this, what we call an effusion, a joint effusion, E-F-F-U-S-I-O-N.
Right.
And that's just the fluid. We can take that fluid off. Sometimes we can look at that. If we think somebody has gout, we can look at it like the
Under the microscope,
gentleman,
light up
you
like
know,
a Christmas tree.
you know, so that, and then as far as nutritional sources of anti-inflammatory,
Right.
okay, we're talking about, you know, the fish, the saltwater fish, you know, with the fish oil,
Right.
is a good,
Do you like,
good thing.
you prescribe fish oil?
You know what, it's an adjunct. I don't know anybody that I've ever seen that said, oh gosh, I'm taking 2,000 milligrams of you know, the whatever the favorite is.
Fish oil? Chondroitin
oil.
sulfate?
All right, chondroitin is not an anti-inflammatory, and glucosamine is not an anti-inflammatory. A lot of, you know, there seems to be some people that can respond to that with osteoarthritis, but it's very unpredictable.
All right.
So yeah, you know, there's really nothing.
Omega-3 things?
You know, and people have come. I mean, I could make a list as long as 2 arms of things people said set off their arthritis, and I believe every one of them. Okay.
Right.
And what I tell people is, you know, if you find out that you eat chocolate and the next day you can't move around and you're swollen, for gosh sakes, don't eat chocolate.
Yeah.
Okay. If you drink red wine and you can't move the next day, don't drink. If you eat chicken and you can't move the next,
Right.
because you're swollen. You know, if you find things that are unique to you, okay. Don't scream to the world, oh gosh, you know, this
Chicken is the cause of all problems.
you know, this is your deal. Okay, you're a unique individual. If you find things that set you off in terms of these
Right.
these immunological diseases, then you need to cut them out of your diet.
Right.
You know.
But you haven't made a big fuss about nutritional supplements or nutritional things or copper bracelets or supplements of any
Copper
kind.
bracelets were dispelled, you know, back in the 1960s. So that's old news. But they're still around, you know.
Yeah.
But,
What are the other big errors in judgment as far as treatments?
you know, you know, the soaking the white raisins in gin.
Right.
Use that. Alfalfa pills.
Right.
The
The gin is good. The raisins.
The raisins aren't worth a hoot after
Okay.
that. you
All
know.
right. Okay.
It wrecks raisins.
It does. It just messes those raisins up. Here is someone who has arthritis in both hands and ankles. He's a smoker, wondering if arthritis can be affecting his lungs.
So cigarette smoking.
Yeah, does
and
it affect you?
arthritis. You know, clearly, it's one of the things that makes rheumatoid arthritis worse. Doesn't cause it, okay? But if you've got rheumatoid arthritis and you're a smoker, you're really making it hard on me to try to
to treat them.
To treat that.
So arthritis and smoking is correlated. How about Berger's disease? Explain that. That's a vasculitis, which is in your immune system.
It's a vascular disease. That then you get some, there's vasculitis, which starts out as a primary inflammation in the wall of the vessel, okay, and then can cause problems. And the classic being giant cell arteritis, where you get inflammation in some of the arteries going to around your eyes and your brain. But then there's Berger's disease, which seems like the inflammation comes after the ischemia is there, and it's the nicotine or the whatever it is in a cigarette that makes that disease go, and then it gets inflamed after that, and then you end up with those,
lost hands and fingers and so on.
Yeah.
Okay, so we're going to just fire through this. We're running out of time. Spinal stenosis, how do you treat it?
Spinal stenosis, sometimes you don't have to treat it. Sometimes you can have an injection that will reduce that
Steroid
swelling.
injection, yeah.
And sometimes it needs to have surgery.
Here's another spinal stenosis. From Nunda, this one's from Winter. Autoimmune disease, fibromyalgia rheumatica. Always.
Not such a thing. There is no such thing as fibromyalgia rheumatica. Okay. There's polymyalgia rheumatica, which is a muscle stiffness, aching thing. There's fibromyalgia, which is a pain syndrome, which is, we don't know
what it is, really.
What it is exactly, except it's a pain syndrome. Pain specialists treat that by and large. It's not an autoimmune disease.
Always feel very tired, wondering why is on prednisone 7.5. Polymyalgia rheumatica, that's an interesting condition.
Yeah, polymyalgia rheumatica. Yeah, it is inflammation that affects larger joints and muscles, and without destroying the muscle, without destroying the joint, but can make you profoundly stiff. And it's very, very responsive to low-dose prednisone.
That's the great news. Aberdeen, what causes foot fractures and how can you prevent them?
Stress fractures, I assume what they're talking about. Sometimes it's just bad luck.
Yeah.
Okay. You get a bone structure there. I've seen people have been sent to me with a stress fracture and a metatarsal.
Yeah.
Work them up for osteoporosis. They got perfectly normal bones. They just have some abnormalities there. Other times, it could be a sign that there's something else, osteoporosis or something else going on.
All right. What can be done for fibromyalgia? That's the other question.
That's a
pain syndrome.
It's a pain syndrome. We really depend on the pain management specialists to deal with fibromyalgia because it's really multifactorial and it's really not an autoimmune disease in the sense that we would be treating lupus or rheumatoid or something like that.
Okay. Uloric medication and the side effects.
Uloric is a medicine to lower the uric acid. Febuxostat is the name, and it is different from allopurinol, but it works through a similar mechanism, and it
prevents gout.
It's one of the newest things we have to lower uric acid.
Any major side effects?
Well, all these we watched liver function, we watched, but not
as much as allopurinol. Allopurinol has significant side effects.
Yeah, maybe. I don't know.
You're not impressed by the side effects of allopurinol.
Well, I'm really cautious in using it and how I started and watching people. But I would probably scare you if I told you what the highest doses I've used of allopurinol. 800 milligrams a day is the highest dose.
I mean, what can be done for a 92-year-old? See, 300 is, I'm at 400 maybe at the most.
I know.
What can be done for a 92-year-old woman with shoulder pain? Shoulder pain. I've just seen all this shoulder pain in these last, years.
Well, first of all, shoulder pain can be the onset of polymyalgia rheumatica, and it can be really sneaky. It can be painful, stiff,
have your doctor
achy.
check a sed rate.
So a sed rate, a very simple blood test, okay? If you have and again, sed rates go up a little bit with age. So a 92-year-old, I would expect a little bit of an elevation in sed rate, but if a sed rate is 40 or 50, you might be onto something there, okay? And one is it stiff, one's it sore. Degenerative arthritis is probably the most common thing, and it's just wearing out that ball and socket.
So are you sending a lot of these older people for shoulder surgery?
No. Just try to do physical therapy, get them moving, heat, whatever.
And the information Gus today, thank you for your program. What is the effect of gout on the liver? That type of question. Gout in the liver.
The liver gout thing is probably the connection is the medication and not the gout. The connection with the other organ system would be the kidneys, though, because you can have uric acid kidney stones. Okay.
Right.
So if you're peeing out all this uric acid, you can form stones, and
So there it is. I think that's it. We've got to be careful about letting gout alone because you can destroy your kidneys.
Yeah, hyperuricemia is a big deal. I mean, and there's more and more research going into hyperuricemia, so people need to pay attention to gout and hyperuricemia in particular.
They've talked about our heart disease as a result of
It's all on the table.
elevated uric acid levels.
It's all being looked at.
From Brandon, the CCP antibody comes back positive. Do you have a more severe case of arthritis? What is the CCP?
We talked about the rheumatoid factor being the old classic one. So if you're rheumatoid factor positive and CCP positive, and clinically it looks like you have rheumatoid arthritis, you're in a more severe, potentially prognostic group. I would be more aggressive with that person than somebody that, say, looks like they have rheumatoid arthritis, but the rheumatoid factor is maybe negative and the CCP is negative. But they still have rheumatoid, but they're just in the negative.
Right.
I'd be more aggressive with somebody that had CCP positive.
Aggressive, start the methotrexate.
Yeah.
There you go. 84-year-old from Sioux Falls. What are bone spurs? Why do they occur, and what can you do about them?
Bone spurs are just outcropping of bone, okay? Right. And if you think about this, okay, if you injure a bone, if you fracture a bone, okay, and then you follow that fracture along over a period of 3, 6, 9 months, what do you see? It forms a callus around it. Okay, which is excess bone, and then your body gradually remodels it back to normal after a year or so, okay? The same thing, if you injure the bone around the joint, okay, your body reacts to that. It throws bone in there. It's like a little callus, except you keep repeated injuring it so it grows and grows and grows. And then the spur itself becomes the thing that is irritating the tissue. I tell people, like the end of your pencil here, okay? This is the spur. Now, if I did this and I just kept rubbing, it wouldn't take very long. You had a red sore spot right there. That's a spur on the inside of that joint. And every time you move that finger or that knee or whatever, that spur is moving.
Well, what about taking it out surgically?
It'll come back.
So you don't take surgery?
You don't take them out. You learn to use the joints differently. You learn to exercise the joints differently. You do different kinds of exercise. You can take those spurs out surgically, but if you don't address the underlying problem and structurally why that occurred, it'll come right back.
All right, so we've got less than a minute. Psoriatic arthritis, or do you want to take home message?
Psoriatic arthritis is if you've got psoriasis and joint pain, somebody ought to think about whether you have psoariatic arthritis.
And there's some good treatments.
There's some really good treatments.
And you want to make sure that people remember what when they go home? We've got 40 seconds.
That if you have new onset joint pain with constitutional signs or symptoms with that, sit down with your doctor and talk about this, go through it with them, and if it's still kind of a puzzle, have him call your local rheumatologist or whatever and get in there and have him take a look at it.
Don't sit on it.
Don't wait.
Thank you so much for this, Jim. We'll be back right after this.
Quit smoking, and in just 20 minutes, your blood pressure returns to normal. In 12 hours, carbon monoxide levels in your blood drop. In 48 hours, your sense of smell and taste improve. Within 2 weeks, your lungs work better, you heal faster. 9 months means more energy, fewer illnesses. And in 5 years, your risk of heart attack is half of what it is now. Take a deep breath. You can do this.
Mrs. A was not one to complain. She was a hard-working farmer who had recently lost her husband of 59 years and continued to live alone on the farm, though most of her chores were now done by a hired hand. Pain and stiffness were not new to her, but recently there had been some new life-limiting neck, shoulder, and pelvic stiffness, along with a loss of appetite and weight loss. As she was close to 80, she blamed it on her age, an old mattress, and work in the garden. But it had become so bad she was having difficulty getting dressed. Her kids made the appointment to come in and see the doctor. On the day of her exam, she seemed slower and a bit depressed, had a low-grade fever, and though she did complain of pain as I tested her, the strength in her arms and shoulders seemed excellent for a woman her age. The rest of the exam was normal, and my suspicion of Polymyalgia rheumatica, or PMR, was validated when a blood test called the erythrocyte sedimentation rate, or SED rate, was high. The SED rate measures how fast red blood cells settle in a test tube, measuring how much inflammation is going on. The good news is that PMR responds remarkably to low and easily tolerated doses of steroids. I put her on 5 milligrams of prednisone, and in a week, she was a new woman and back in her garden. She stayed on that dose for a couple of years with minimal side effects, and finally was tapered off 1 milligram at a time over a 5-month period. Polymyalgia rheumatica means many muscle pains due to an immune system problem. And we think it might be a viral triggered process that happens more frequently in certain families. Usually PMR occurs in those greater than 50 years of age with an average incidence of 70, and occurs more than twice as often in women than in men. It's important to know that 15% of the time PMR runs with another problem that can cause blindness. So, severe muscle stiffness with vision changes should get immediate medical attention. That said, most stiffness with age is not PMR and gets better with movement and exercise. However, if there is a new life-limiting neck, shoulder, and pelvic stiffness, it could be polymyalgia rheumatica, and there might be some help to get you back in your garden. Well, this brings us to the end of our show this evening. I sincerely thank our fantastic guest tonight, Jim Engelbrecht, not only for being a guest tonight, but also for donating his time to Healing Words Foundation as a member of our board of directors. We sincerely appreciate your wisdom and all your expertise and time. Thank you, Jim. Our friends at South Dakota Helpline Center are having a 5K run walk at the SDSU campus on Brookings on Saturday, April 11th, to raise funds and awareness of suicide prevention. For more information or to register, go to helplinecenter.org or call 1-211. It was Benjamin Franklin who advised us, be temperate in wine, in eating, and sloth, or the gout will seize you and plague you. And from all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
All cancers give us reason for concern, but cancers found in the head, neck, and brain can bring particular anxiety. Cancer above the shoulders. Next time on Call with the Prairie Doc.
Funding for On Call with the Prairie Doc is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
LARSON Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota.
Additional funding is provided by
Aberdeen Asthma and Allergy,
Brookings Health System,
Dakota Allergy and Asthma,
Dakota Care,
Dakota Dermatology,
the Orthopedic Institute,
Physicians Care Sanford Clinic Community Service Committee,
and Swiftel Communications.
Closed captioning for On Call with the Prairie Doc is provided by the generous support of
Avera
Brookings Health System
and Fishback Financial Corporation.
Hello and welcome to On Call After Hours, where we answer the questions we weren't able to get to during the broadcast portion of our show. All of your questions are important, so we want to answer them as many as we can, so that's why we're doing this. Jim, let's go right into this. Brookings, 63-year-old person, 27-year-old daughter, has rheumatoid, is treated with biologic medication. She wants to have a family. Will they keep her from having a pregnancy?
No. If it's biologic alone, okay,
Right.
if she's just on a biologic without methotrexate, shouldn't be a problem. It should be okay. Okay, I mean every indication right now is that it's okay.
Wow. 80-year-old Parkman, Wyoming. I have severe osteoarthritis and get injections 3 times a year in the hip. Would it be safe to increase the number of injections? Good question.
Well, I presume they're getting steroid injections.
Yeah.
Okay, and in weight-bearing joints, about 2 and at most 3 times a year is all you want, because if you
Enhances
get
the
too much
dystrophy.
steroid in there over too long a period of time can make it break down a little bit faster. So I would stick with, I wouldn't do it any more than 3 times a year for sure.
All right. Let's see, diclofenac.
Yes,
Ulcers and
diclofenac, right. Voltaren.
Voltaren, diclofenac, ulcers in the stomach, intestines. What is a better alternative treatment?
Well, again, non-steroidal anti-inflammatories are, you have that same potential problem with all of them, but just because you have a problem with one doesn't mean you're going to have a problem with another.
Celebrex is a big one that people use.
Celebrex would be, if I had somebody that had ulcers with a traditional NSAID and I still wanted to use an NSAID, I probably would use Celebrex. It has a little less GI irritation than the other ones.
But
in general, you got to be careful with any of them.
Any of them. So probably get off of that, try something
Oh, yeah, I
else.
wouldn't take that one anymore.
Well, that's for sure.
There's 26 other ones you could try if you had to.
Okay. Daughter has rheumatoid arthritis and GI issues. Is there a correlation? Also, how can she manage her symptoms? So GI.
So, there's what's called enteropathic arthritis, which means that people that have certain inflammatory bowel diseases, like Crohn's disease, ulcerative colitis, can also have an associated arthritis. And so when we have somebody who has what looks like rheumatoid or could be a variation of rheumatoid, and they also have bowel issues, it's very important to get the bowel thing worked up, because they may have something that is related there, the inflammatory bowel thing. By the same token, a lot of people with rheumatoid arthritis, because of the meds we use, get GI issues.
Yeah.
And so you got to be, if you had somebody who was taking, say, a couple thousand milligrams of ibuprofen a day, plus methotrexate once a week, plus hydroxychloroquine.
It's amazing
plus
your
some
gut isn't
analgesic,
hurting worse.
Yeah, I mean, you would expect that you might have some GI things.
But people who have Crohn's disease or ulcerative colitis sometimes are treated with the biologic medicines that are used for rheumatoid arthritis.
Yeah, I mean, then you got a twofer, okay?
Yeah, twofer.
Yeah,
Okay.
2 for 1.
Yeah. 68-year-old from Viborg, patient rheumatoid arthritis for 8 years. Is there a diet for this patient?
With rheumatoid arthritis?
Yeah, rheumatoid arthritis, is there a diet you would recommend? Not really. Doesn't matter.
No.
Not an issue.
It's, there's no, it's like I was telling you during the course of the program. I mean, if there's something that seems to set you off as far as your arthritis is concerned,
Avoid
then,
that.
I mean, if you have a bad day with your arthritis, you got to think about what you ate the day before. If you ate something unusual the day before, then test it again, okay? If I ate shrimp, okay?
Right.
And now I'm just have a terrible day, in a week or so, eat some shrimp again. And if you have a terrible day, guess what? You just found that you may have a shellfish something or other that's setting off this immunologic thing.
Wow.
And it may be very subtle. So that's unique to you. But we can't go to the whole world and say, don't eat shellfish if you've got rheumatoid arthritis.
Right. There you go. 72-year-old Clear Lake patient. How does psoriatic arthritis compare to rheumatoid? Psoriatic versus rheumatoid arthritis.
Well, I don't mean to make this more complicated than this, but just for starters, there's 5 different kinds of psoriatic arthritis.
It is just. So is it an immune system where your body takes off against your?
The plaque psoriasis is an autoimmune.
Right.
Thing,
Okay.
Okay. All right. But there are all kinds of variations that can affect the joints. You can have 2 autoimmune things, rheumatoid arthritis and psoriasis in one person. Okay, and that's just 2 relatively common diseases that showed up in the same person. You can have a plaque psoriasis and what looks like rheumatoid, but serologically the blood tests are all negative. That's another form of it. You can have psoriasis, and then you have what we call oligoarticular arthritis, where it's a wrist and it's a knee and it's an ankle, 3 joints or 4 joints. That's a form. Then there's another form where it tends to hit these joints, which rheumatoid never does, okay? And so you can get inflammation and destruction in some of those outside joints, the DIP joints. And then there's a very mutilating form, which I have personally never seen. It's so rare, I have never seen it.
What is it called?
It's called arthritis mutilans, psoriatic arthritis mutilans. I've never seen it.
Okay.
I've seen pictures of it, but I've never seen it.
I'm glad, and I hope you never see it.
I hope, well, and chances are it probably won't.
Caller? Arthritis with fluid buildup that needs draining. How can they stop the fluid that builds up in the joint?
You got to figure out why it's
building up.
Building up, because if you just take it out
it'll come
and
back.
you don't do anything, it'll come right back.
How about injecting a steroid in it?
Yeah, but if it comes back, then you still got something, you need to control the disease. If it's rheumatoid causing the effusions, you got to control the rheumatoid disease or they'll just keep coming back.
All right. 56-year-old woman with MS and 3 different kinds of arthritis, currently in an MS hug right now. What can you do about it? MS hug. Do you know what that is? I don't either. How about MS and other kinds of arthritis? Do you have any knowledge?
No, MS is probably some kind of
immune
autoimmune
system.
or immunologic mediated thing, but
it attacks different spots in the brain in different periods of time.
Yeah, but there's no really real relationship. Now, I've had people who have had MS who develop rheumatoid arthritis, but that's just, again,
2 different
luck.
diseases.
Okay.
How about biologics that you would treat the rheumatologic disease? Does it help MS?
In fact, it's even worse than that. Sometimes we have to be careful when we're using the biologics because we can provoke MS-like reactions in people. So a side effect, unusual, very unusual. I can maybe 2 or 3 times I've seen this in 15 years now of using biologics, where I've provoked an MS-like reaction where I stop the medicine and those neurologic symptoms go away.
So they advertise those biologics on TV. For example, you've seen the Humira and Enbrel
right.
and that kind of a thing. Do you feel that that's responsible? That people would say, I want to have this, doctor, and the doctor would give it? Or what's your take on all of that advertising?
No, the thing is that first of all, let's go back to the beginning. You need to make a prompt diagnosis of rheumatoid arthritis, okay? And I think the rheumatologist, more than anybody, can size things up in terms of what are we dealing with here. What's the prognosis going to be for this patient? You know, we have disease activity indicators that we can use lab-wise, joint count-wise,
Right.
patient digital scale-wise, that they can tell us how much pain they're having, those kinds of things. And we can come up with an idea of this is going to be really aggressive disease, or maybe this isn't going to be such aggressive disease. And then you start a plan at that point. If it looks like it's going to be really aggressive disease, I'll have them on methotrexate right away, okay? Right away. And if that methotrexate isn't turning them around and making them functionally almost normal in 3 to 4 months or so, I'll be very quick to add an Enbrel, Humira, something like that.
But this should not be something the patient encourages the doctor to do and the doctor will do it. It should be without influence by the patient's advertisement.
You know, I mean, you know, direct consumer advertising to me is a double-edged sword, okay? I encourage people to learn about medicine and to learn about health and to come and ask me questions. And if that commercial makes you come and ask me about Xeljanz,
Right.
okay, great. We'll talk about Xeljanz. That stimulated that. If that commercial makes you demand that I give you Xeljanz when I don't think that's the right thing, then it's doing a disservice.
Right. 55-year-old male, scleroderma, 4 years. Any closer to finding a cure for scleroderma? Current drugs weakening the immune system. Well, I mean,
You know,
scleroderma, tell quickly what it is.
Scleroderma is a disease that involves, I mean, scleroderma, literally translated from Latin, is hard skin. Okay.
And that's what it is.
And it basically is a replacement of normal collagen and subcutaneous tissue with fibrous tissue, and so
Scar
you end
tissue.
up, and then it can get into the lungs and it can get into the kidneys and all those kinds of things. And unfortunately, it's not the classic autoimmune like lupus or rheumatoid where you have this inflammation that you can control with these different drugs. You have this sort of fibrotic tissue replacement process going.
Has nothing to do with fibromyalgia.
No, absolutely nothing to do with that. But here's the thing with, first of all, what can look like, oh my gosh, this is scleroderma and this is going to be a downhill glide path, all of a sudden flattens out and it doesn't progress.
Right.
I've seen people who I thought, oh my goodness, you know, we've got all this scleroderma going on, and then all of a sudden it kind of stabilized, and yeah, they ended up with some Raynaud's, some cold sensitivity, and some hard skin, but they never got the other things. And so, you know, it's not one of those things where you wring your hand and say, okay, I'm going over the bridge, okay?
Yeah.
It may stabilize, okay? And
Okay.
So
There's hope.
There is hope.
Dupuytren's contracture in hands. How can you care for this, and when can I receive care? This is a person with rheumatoid arthritis, but it doesn't have to be rheumatoid arthritis.
No, in fact, most people who have Dupuytren's contracture don't have.
Do not have rheumatoid arthritis.
It's mostly hereditary. And it's just a contraction that you get down in the tissue there. You see
and
that?
It brings this down and this one, right? You have a little bit.
I'm getting a little bit of one.
Yeah.
So it brings it down like this. It wants to bring it down. And what you do is you keep resisting that, okay? And it stretches it out and stretches it out. And if you keep stretching it out, now if it can't be stretched out, there is a little surgical procedure they can go in and take it, but it tends to scar down again. And so it's better just to.
But it isn't the tendons that open and close your hand. It's the fibrous tissue
alongside the tendon.
Yeah. So you can fix it again. Raynaud's.
Yeah. Cold sensitivity. So Raynaud's is an overreactivity to cold, and so if you think about this is a blood vessel, okay?
Right.
This is your skin. And you go outside in the Brookings winter.
Yeah.
Okay. And it's cold.
And it's
okay?
cold,
and that blood vessel, your body says, oh my gosh, we got to conserve heat. And what's it do? It squeezes down like this.
Tightens up.
It tightens up, and so it forces that blood to stay where it's nice and warm on the inside here, not out here.
Right.
Okay. What happens in Raynaud's is it tightens up, but it forgets to let go. So when you do it, it tightens up, and then you put your gloves on and your mittens on and everything, and then it kind of relaxes. Says, okay, well, we can handle this.
Yeah.
Okay. With Raynaud's, it overreacts, and so you end up choking off the circulation to the fingers, and you get white fingers, and then after a while they get really kind of dusky looking because there's no good blood flow there, and then suddenly it'll open up and it'll get bright red and it'll sting, and that triphasic white, blue, red is classic Raynaud's, and you can have variations on that theme, but that is seen in people that have inflammation going on in their joints and their hands more often. And so with all of the arthritic connective tissue autoimmune diseases that we have that have small joint inflammation, they tend to be cold sensitive and have a little bit of Raynaud's.
Right. But you could have just Raynaud's
You
without
have
rheumatoid
just
arthritis?
Raynaud's, right. And it can come and go, and it can come and stay.
Okay. Here's one on polymyalgia rheumatica. We just talked about that. What can I do about hand, foot, and leg cramps?
Stretch.
Yeah.
Make sure you don't, keep your electrolytes in balance, and then there's a bunch of home remedies.
Right. My answer to that one is that it commonly is because the fluid goes in and then it goes out, or it goes out and then it goes in. I mean, it's a fluid change. People who have edema in their legs get the support hose.
Right. I use, classically, I mean, this is partly urban legend, okay,
Right.
partly myth, okay, but I'm going to tell you anyway. But
Tell me anyway.
quinine pills.
Right.
For cramps.
Yeah.
Right.
Right.
So right now you can't buy quinine pills because they did one of those funny drug things, made them really expensive or whatever, and you can't get it. But you can get quinine, and it's called tonic water.
So a little bit of gin and tonic.
No,
you don't need to have
the gin out. Just leave the gin out. Just take a little juice glass of tonic water when you go to bed at night. Sometimes it'll
help you a little bit.
Make the medicine go down.
Yeah. Are infusion therapies more harmful than injections for long-term use? Do you know what they're talking about?
Yeah, well, like Remicades an infusion, Rituxan's an infusion, Actemra's an infusion.
Yeah.
Humira, Enbrel, Simponi, Cimzia, those are injections. There really is nothing that would make one more.
How do you pick your? Because I haven't learned the direction on those. Do you always start with Enbrel? Do you always move on to this or that? Or did
part of it is Enbrel was the first one out there. Okay, so Enbrel, then Remicade, then Humira. They were the first ones out there. So that's what we have the most experience with.
Right.
And I always liked the nature of Enbrel being a relatively short act. I was nervous to begin with.
Right.
I'm going to give you something that you got to take every 3 or 4 days, but if I start having problems, guess what? In 3 or 4 days, I can have you away from it.
Yeah.
If I give you something that you get every 2 months, I got to deal with this for the next 2 months if you get an infection or something like that.
Yeah.
So theoretically, I like the shorter acting ones, and so I got a lot of experience with Enbrel and Humira. But then there's times when I really want to be able to control the process, and Remicade is a much better choice because I can really fine-tune that process.
Right.
And so that's,
Through the years, that's where you've come.
It's an experience.
One final word about fibromyalgia. No one believes how much pain it can cause. She's kind of desperate. What would you call fibromyalgia, and what does your help?
Well, fibromyalgia, I mean, it's a pain syndrome. It is. The things that we know about it is that there's an overactivity in the pain fibers, in the nerves,
right?
In the pain fibers. Yeah. Okay, so it first of all, makes you more sensitive to touch. Right. You can get tender areas and places which would normally be tender if I pushed hard enough.
Right.
I don't have to push very hard and they're tender. Okay, and so that's how this tender point business came along.
Right.
And it's like you've got this hyped up pain nerve system in your body. Now we don't know why that is. It's not autoimmune. I can give you prednisone. I can give you it doesn't have nothing. But there are some medications out there that will slow those pain fibers down a little bit. Things like amitriptyline, the old tricyclic antidepressant, and some of the derivatives, some of those medicines, gabapentin, Neurontin, Lyrica, one of the newer ones, sort of son of gabapentin.
Yeah, son of gabapentin.
Yeah. That will slow that down and help that. The other thing is that good rest is very helpful. So that back in the days when I used to treat fibromyalgia, I would use things that would help, not sleeping pills, but I would use things like amitriptyline or cyclobenzaprine or nortriptyline or something at night to try to people rest. And then we would start a very gradual, graded exercise program. Yeah. The worst thing you can do is to say, go exercise, and because you'll overdo it and you'll feel terrible. But if you go and you just start really, really gradually, just a low grade, I tell people to start embarrassingly little. Okay, in other words, I put my swimming suit on and I stuck my toe in the water and then I put my clothes back on and I went about my business. That's the first week, okay?
Yeah.
Then I stuck my whole foot in the, you know, I mean,
gradual.
I'm exaggerating,
Right,
but it doesn't matter whether it's walking or bicycling or whatever. You walk around the track once and then that's it. And then tomorrow you walk around the track once and that's it. And then next week you walk around twice, 1.5 times. And the week, I mean, there's no race here, okay? You've got the rest of your life,
Right.
okay? Go slow. And the more exercise tolerance you get, so if you can rest at night, you can get the exercise tolerance up, you can use some judicious analgesics, not narcotics,
Right.
okay?
Avoid the narcotics with that one.
You can control to the point where you can live reasonably sanely, okay?
Yeah.
And not be going crazy with pain all the time.
And stay in touch with your doctor because there might be something else that would raise its ugly head eventually.
Yeah.
Well, Jim, thank you very much for being with us.
Yeah.
This has been great
good.
fun and very learning for me, as always. Thank you for joining us on our website. We appreciate all your questions and the opportunity to answer them. Until next time, stay healthy out there, people.
Chart, computer, that kind of stuff. Yeah. So when do you want me to do this? Do you want me to start with this
Right.
funding for on-call? Like that?
Yep.
Okay.
Start it.
Funding for on-call with the Prairie Doc is provided in part by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Aberdeen Asthma and Allergy, Brookings Health System, Dakota Care, Dakota Dermatology, the Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, and Swiftel Communications. Closed captioning for On Call with the Prairie Doc is provided by the generous support of Avera, Brookings Health System, and Fishback Financial Corporation. That it?
Wow. All right.
Good.
And then do one little promo. So, two promos? Okay.
Okay, this is our invention. It's called the doohickey.
Called the what?
The doohickey.
Yeah.
It's for opening doors. It suctions onto a door. You use like your elbow. Something we've found is that some people who can't grab those little handles,
Yeah.
they like because they can just push it.
Yeah. That's kind of cool.
So
All right. Pull.
if we gave you some, would you have any patients that might want to try it or see if it works? Or
Yeah.
would that be something good? So if we sent you a few?
Sure.
Because it's something we'd like to promote a little more. We'd like to sell the damn things is what we'd like to do, but that goes down the road
It's-
further. But
It's Jay's invention.
yeah, we invented it, and it's made right here in South Dakota. And
Yeah, give me just, and I've got some people I'll, because I have people, first of all, that, they have a hard time handling doors anyway.
Right.
Okay, and so this would be.
yeah, or even just because you can just push against it. The trick is getting it on right. Once you get it
Yeah.
on right, it holds it.
All right.
So
Yeah.
Why don't you wait?
just
Wait.
Just wait for a minute until it gets on.
And I'll do my promo thing, and then we'll be done. You ready? How we doing?